the year. Good to see you all again. And let's kick off then. Apologies. I think, Lisa, we have a number which we'll add into the minutes. Normal housekeeping. People clear about all those points? Yeah. Okay. Let's then move on then to the minutes and the action log. In terms of minutes, any matters of accuracy people want to raise? No. Okay. Action log. Lisa, anything in particular you want to highlight for us?
Okay, so with regards to the actual log I'm sharing, the closed or the completed actions I've now closed off. But I think it's important to still share with the group any updates on them. So you will have seen, obviously, from the action log I circulated last week, any updates that had been given. So we've only got 4 outstanding at the moment. We've still got to arrange a meeting with regards to myself, Nathan and Patrick to talk about data and how we're going to share that with the team going forward. With regards to the development around the engagement strategy, I'm going to talk about that anyway a little bit later as part of the agenda. Unfortunately, with regards to the report for the psychology team, that has now been postponed until probably April. So we were hoping that both Luke and Rachel would attend this meeting today, but unfortunately we're going to have to postpone that until another time. And then lastly, with regards to the role description about the delivery group. So Kath Gree has put an expression of interest in. We're going to be picking up with her and Patrick about kind of the elements to take that forward, and also then for her to be endorsed by our clinical director on the delivery group if Kath is happy with regards to the expectations. So that's really positive. You know, it's great that we can have patient participation across all of our main groups, sort of this group in particular, the exec board and delivery group. So I'm really pleased about that. And that's it with regards to the action log.
Okay, thanks, Lisa. Okay, let me move on then to the executive board update from January. On the next slide. Okay. As I think Jen presented a paper on personalised care. I'm simply just for, I mean, it's a concept that's been around in health and social care for some time, and many of us will be familiar with it. I thought it was just helpful to remind ourselves of what it was about, about what it aims to do, and what it's very much focusing on, which is very much kind of health and well-being, and recognizing that we need to be doing much more in terms of self-management. Working alongside professionals, and clearly we would want to make sure that the belief was actually delivered on, that it will actually improve treatment experience and outcomes, and very importantly reduce health inequalities. Jen obviously is still involved with her other meetings, so I suggest that we perhaps come back to this slightly later on and give her an opportunity to comment on it and to say anything more that she wants to. People happy with that?
Yeah, thank you.
Okay, then the next slide then. You may remember that I did a presentation to the executive in October, and what I've highlighted here is very much what I thought the key questions were. And as I reported at our last meeting, it was very well received. And what I wanted to do was to try to ensure that the executive actually, rather than, in addition to listening and hearing, I felt it was important that there was an agreement to do something about it, and therefore to make sure that we understood what was happening at each trust level on a regular basis. So therefore, I think it was very helpful that there was an agreement that the lead cancer nurses would actually share updates on each trust action plan at the next meeting in April. That's really all I wanted to say on that, unless people had any questions or comments. No? Okay. Jen's obviously still involved with our meeting, so can I suggest that we go to item 4, which is Health Watch item with Emma. Are you here?
I'm here. So I'm muted, and unmuted again. So
Okay.
hi.
Over to you, Emma, then, please. Yep.
Thank you. Thanks for asking me to attend today. Lisa and I have been trying to get me into this meeting to talk about the work that Health Watch Oxfordshire do around patient participation groups. So you're known as a PPG, Patient Partnership Group. Well, we work with patient participation groups, and they are different in the way that they work. So all being well, I should be able to share my presentation. Okay, can you all see that?
Yes, I can.
Fantastic. Technology at its best. I did send it to Lisa just in case it failed me. So what I thought I would do is just give you a brief explanation as to who we are as an organisation first, for those of you who aren't aware about what Health Watches are and what they do, and then how our work with Patient Participation Group is supported. So Health Watch Oxfordshire is an independent charity, and we were set up in 2013 as a result of the Health and Social Care Act 2012. We are obviously aware now that the Health and Social Care Act has changed, but we were set up due to the 2012 Act. Our role is to listen and strengthen the collective patient voice. So this is what is important. It's hearing from the patients. We inform service providers and commissioners about what we hear, and we help to influence change. So we help to recommend where things need to be made better for the patient. We work as a critical friend who can sometimes provide the bridge between that patient and a service. So as a general rule, Health Watches don't deal with individual cases. We strengthen that collective voice. But sometimes there are occasions when we're needed just to support a patient and link them with an individual provider. So how do we hear and listen to people? People contact us by telephone, email. We do get the odd written letter, which is quite nice to still receive. We have a feedback centre and feedback forms. This provides people the opportunity to actually give feedback on services that they've used. And the good thing about this way of giving us information is that actually providers get to see and hear what people have said about them, and they actually have the chance to respond. So it's quite nice because that individual person gets an individual response from some providers. We are working on trying to get more providers engaging with the responding side of this way of receiving information. We do surveys, we do outreach. Last year we restarted our visit to the 4 Oxford University hospitals, where we go and visit for a morning and we talk to people about their experiences, not necessarily of just using the hospital, but of any other service, health and care service within Oxfordshire. We go to local towns, we work with local groups, and we also work with the voluntary sector, which is really, really important. And then the bit that leads on to why I'm talking today is about working with patient participation groups. So what is a patient participation group? Part of the GMS contract is that every GP practice should have a PPG. I say should have a PPG. Some practices do find it quite difficult to get patient engagement by way of face-to-face. So they sort of need that extra support to be able to get patients engaging, whether it be by email, by text. Just some response is classed as having a PPG. PPGs are critical friends. They're critical friends of their practice, carrying out research with the practice, putting on health talks, and listening to what the patient has to say. It's passing on that feedback and the information. Anybody who's over 16 can join a PPG. This is just a poster I designed last year for the PPGs to use. They can adapt it for their own surgeries. And it just is simple information. So there's not lots to read. People can understand. provide feedback to your surgery about its service, make suggestions how it can be improved, and promoting health and wellbeing. So Healthwatch Oxfordshire was commissioned by the Oxfordshire Clinical Commissioning Group to provide additional support to PPGs. I think it was about 6 years ago now. And we do this by promoting good practice between PPGs. We support the PPGs to work together. So we've done that by having several forums. Unfortunately, COVID put paid to the face-to-face forums, but we are really hoping that they will perhaps restart again in the near future. And we help PPGs to support and develop their working relationships with each of their GP practices. We accept that all of them are different. So what do? I communicate mostly weekly with the PPGs, providing information about local PPG support. I attend PPG meetings at their request. We do a PPG newsletter. And all of this information includes what's happening in and around the county. So it's not necessarily all focused on patient participation group work. It can be what's happening in and around other stakeholders, organisations in the county. So it might be that consultations are looking for patient engagement. It might be that patients are being requested to attend other meetings, or that they might be interested to attend. And we encourage them to share good practice. So where one practice, one PPG might be doing a newsletter or putting information on their website, their GP's website, we encourage them to share that. So other PPGs who are perhaps quite not as proactive might have that information to be able to do something for themselves. Looking forward, I didn't use the NHS speak of going forward. We're focusing on communications with the PPGs working within the primary care networks. That is still a work in progress. We are fully aware that actually the PCNs, the primary care network, should be engaging with the patient voice within their communities. So that is work in progress. And then I've put here monthly webinars. So patient information webinars were originally set up to support the PPG chairs, members, and any patients who wanted to come and listen. And we used topics of relevance for them to hear about. We changed this at the tail end of last year. So instead of calling them patient participation group webinars, we called them patient information webinars. Why did we do this? Because we want to engage with the wider patient network. We realise actually that there's more than just the PPGs want to hear topics of relevance, but it's a two-sided coin. We can also provide these patients or these people who attend the webinars information about patient participation groups so they can find out more about engaging with their own practices. So since December 2020, we've delivered 15 webinars. The first one was around the COVID vaccination programme, which obviously was a highly relevant topic at the time. We had over 100 members attend that meeting. And I've just listed a couple of other webinars that we've done since then. Quick plug for our next webinar. It's a week on Friday, and we've actually got Dan Leveson from the Bob ICB. He's the place director for Oxfordshire, coming along to talk about what the changes with the health and care system in Oxfordshire will be. It's the opportunity for people to find out more, ask their questions, and really about how changes will affect them, because people don't know how they're going to be affected. What is the difference? How will it affect me as a person? So we're giving people that platform to be able to ask that question. If anybody wants the link for that, it is on our website, or ping me an email and I can send you the link. Just a link to all of our pages. So we've got a comprehensive set of web pages for all of the patient participation groups to link into. I won't go into detail. They are active links, so I'm happy for the presentation to be shared so people can have a look at the links in their own time. I wanted to finish with this one because this one is a real key part of our work. Luther Street is a practice that services in Oxford City. It services the homeless community. And a few years ago, we set up a patient participation group there. And we did a film together with a local filmmaker, which actually won an award. And it was about patient voices. Now, as with COVID, with many other PPGs, the group actually stopped meeting. So I've recently started liaising back with the practice and the local voluntary sector who work with the homeless community about how we can re-engage. And I'm pleased to say we've actually got our first meeting next Thursday, week on Thursday. So it's really good to engage patients again. It's a 3-minute video. I think I'm still okay for time, William. Just looking at you for a thumbs up. And if you're happy, I'll just play this video just for so people can hear the patient voice.
Emma, we've got no sound.
Me either.
No sound.
William, you're on mute.
Oh, is that what it is?
Okay. So Emma, the technology is great when it works. So
Can you not hear it?
no, there's none of us can hear the sound.
Ah, this is where technology fails me.
Yeah.
I do apologise. If anybody wants to see it, I'll put the link in the
Okay.
in the chat box. It's just a really emotive video. It's, to me, this is what it's all about when you're talking to patients. It's about their voice and it's about them being heard. And that's what is so important. And I think I don't like technology when it does this.
Okay.
That
Okay.
is the end of my presentation.
Well, we tried.
So-
We did try.
Lisa, you want to come in?
William, yeah. Sorry, I don't know if you've still got time, but when you share your screen, you need to click include computer sound. That's probably what you didn't do.
No, we have got computer sound on there. Unfortunately, we've had issues with the link before, so it's technology and YouTube sometimes don't play ball even when you click the right buttons. But thank you.
Okay, thanks, Happy. Lisa, you want to make a comment?
I was just going to comment on that as well, Emma, but if you have sent me the slides, then of course I'll end up putting the link also on our website also for people to reference. So no problem there. People will have a chance to see it.
Thanks, Lisa.
Okay, thanks, Emma. I'm sure many of us had done work and are aware of sort of health watches, but does anyone want to make any comments or any questions to Emma before we move on? No? Okay, thanks very much.
Can I just say, William,
I'm sorry about the technology. Okay, just let me check. Has Jen been able to join us yet? No. Okay, let's then, if we can skip on then to Vicky, are you able to come in and deal with item 5 about GP nurse facilitators?
Yeah, that's fine. I'm just going to share. Okay, does that come up for you all?
Not yet. Oh, here we go. Yep.
Okay.
Go ahead, Vicky.
Okay, so I just thought I'd quickly go through our new nurse facilitators that we've got in role now. So basically, this was a 2-year project that has been sponsored by Macmillan and the Thames Valley and the ICB. There's already a service established in Swindon, and that's been going for 2 years. So this is going to sort of copy that footprint because it's really successful in that area. So basically, So we've got 6 nurses, all part-time, and they're covering the whole of the Thames Valley ICB area, and they will work with the cancer team mainly in the ICB, and they're bridging the gap between secondary primary care and working mainly on cancer care reviews, which are something that should be offered to all patients who've had a diagnosis of cancer. The first one within 3 months of diagnosis, and the second one at about 12 months. So we found that from the patient surveys that this was not happening, and a lot of the feedback was that once treatment had finished, there was a gap in primary care going forward. So this is what the project was to look at, and to look at actually the quality of the cancer care reviews. There is some quite high numbers of cancer care reviews being delivered because they're actually incentivized within GP practices. But again, even in the early stages of these projects, it was found that the quality of the reviews is what we really need to look at, not just the fact that a box has been ticked to say it's been done. So our nurses have started to make contact with all the GPs. They've been split up into areas, so they're covering different areas, each nurse, but working together on a collective solution to this. So they've tried to establish any leads in any practices that are concentrating on cancer work streams, and they're looking at who actually carries out the cancer care reviews. So it could be a GP or it could be a nurse, and increasingly now we're looking at lots of different roles within the GP practices. So what we're looking at is, can we help them train up social prescribers, even paramedics or prescribers, or any kind of new role that's coming into the practice and they feel that they had the skills to help this. So and it's all part of the personalised care sort of package across the whole ICB. So that's where we come in with, and looking at primary care and how we can integrate with all the different roles. So we've got to the point where we're into Q3 at the moment, their induction and training, and they're finalising their work plans, and then they're going into their delivery now. So a couple of them have actually gone out into GPs and have found very different receptions from different GP practices, which is quite interesting, because they are actually going to take on the role of training in the GP practices, which means that that can release more time for the GPs to actually carry out the cancer care reviews or carry on with other appointments. So it's quite interesting. So we are going to be still looking at the cancer care numbers. There are still practices that aren't reaching the required level of cancer care reviews completed, even if as they are incentivized, which is quite unusual. And we're going to be looking at a number of training sessions. We're looking at how we can feedback from the cancer nurse facilitators, and also keeping up to date with the patient survey to see if we can see any improvements in the local surveys. And they will also be looking at patient feedback from the practices as well. So that's all in the 2 years. So we're into the first year now. And at the same time, we do need to start thinking about how can we carry this forward. We don't want it to stop after 2 years. So we need to think about that in the evaluation as well, to see how we can carry this forward. So yeah, that's the personalised care nurse facilitators that are out at the moment.
Okay, thanks, Vicky. Anyone got any questions for Vicky or any comments? Just one question from me then, Vicky. I mean, we know that one of the challenges around at the moment is actually recruiting staff. So you flagged up about that. I use the word you will recruit 6 nurses. Have you been?
We have, yeah.
That's really good. And yeah. I know that the whole kind of thing, but recruitment can be a real challenge. Okay. Anything else anyone wants to pick up from Vicky's presentation? Okay. I think it's really great to see something which is a kind of a practical application of a personalised care agenda, you know, which is obviously really something really important that we've already touched on, and hopefully come back to briefly when Jen's able to join us. Jen's, I think, still caught up in her earlier meeting. So
I'm here, actually, sorry.
Oh, are you? Oh,
I've just
I
joined.
didn't see you listen. Well, thanks, Jen. Okay. Do you want to, obviously, were you able to see Vicky's presentation? Hello, Jen. Were you able to see Vicky's presentation on personalised care nurses?
I didn't see it. I just joined at the end of that.
Okay. Well, again, I think it was just kind of, you know, a practical illustration of what's happening with the whole agenda. Just before we go on to the strategy presentation, one of the things that I was flagging up at the beginning of the agenda in terms of the executive feedback was just about how your the paper that you presented. I'm just wondering, is there anything that you want to comment on before we move on to your main item?
I don't think so. I mean, I can talk about it as we go on, I guess.
Okay.
And I can take any questions on it. So I think I see quite a few familiar faces on the call here, so I think I've met quite a few of you before, but I'm Jennifer Greystone and I'm the Clinical Director at the Cancer Alliance, and I'm also here representing Kathy Wybrow today, who's our Managing Director, off on some unexpected leave at the moment. So that's why I was late. Apologies, because I'm trying to be two people at the same time. And my background, I'm an oral and maxillofacial surgeon, so my background is in head and neck cancer in Oxford, and I've been a consultant there for 12 years, for those of you that don't know me, and I've worked at the Alliance since 2019. So I feel I've been around for quite a long time now. So it's a pleasure to be here. Lisa, do you want to just come on to the kind of strategy slides, and we can just go through it and we can take some questions as we go? Is that all right?
Yes, sure, of course.
Cool. Yeah, and my internet's been a bit funny today, so if there is any problems, wave at me or do something, all right? Because I've had to do a mixture of phone and computer in some meetings this morning, but I have reset my router at lunchtime and turned everything on and back on again, so hopefully it will be fine. So I was just going to go over a little bit about how we set our priorities for the year ahead, and we're basically, I don't know how much you've covered in this before, but we're basically an extension of the National Cancer Team, who are part of NHS England, and we take direction from them about what it is that they want us to do. So our priorities are very much set by the National Cancer Team, and they come to us with a kind of big list of wants, and then we're expected to deliver that round the system over Thames Valley. And so I just put this up as a kind of timeline of what happens. So the kind of very initial, everything obviously runs on a financial year basis. So the year starts on 1st of April, and we get a kind of initial look at the whole system planning guidance in about December time. And that includes everything, you know, so that's cancer, mental health, primary care, everything comes out in December, and it's a very high level pack. And then in January, we get our specific planning pack for the Cancer Alliance. And it's got a whole list of projects and deliverables that they want us to concentrate on. And it starts to go into a bit more about milestones and trajectories and expected outcomes and all of these kind of things. And it's quite a detailed pack that tells us exactly what they want us to deliver. And we're expected to submit our plan by March. So we're expected to read all the guidance, speak to everybody around the system, and go back by the end of March to say, okay, this is what you want us to do, this is what we think we can do, and this is where we think we are now and where we need to get to by the end of next year. And then there's a kind of review process from the national team on that. We get some further feedback, we get the ability to kind of reshape our plan a little bit to meet that plan, and then it goes in, and by April we expect to get our plan rubber stamped by the National Cancer Team. Then what we need to do is we obviously need to tell everybody what it is that we're planning to do, and we've been speaking to lots of people already, and we've been talking to the providers, and we've been talking to primary care and the system about what it is that we're expecting to do, to obviously hear from them about where they're at, what they think their priorities are, and to try and align everything. We would plan to take a formal paper to our executive board in April, which is something, I can't remember, it says something like the 25th, 26th of April, something like that. And we would plan to take a paper to our exec board at that, to be really clear about this is what we're planning to do next year, and this is what we expect from everybody. And then we're assured by the regional team currently, so it's by the regional NHS England team, and we have quarterly assurance meetings where we're expected to turn up and we get asked questions about where we're at and where we still need to get to, any difficulties we're having, anything that we need help with, these kind of things. So that's a kind of high level timeline of what we're expected to do. So Lisa, do you want to come on to the next slide? Great. So basically our work stream is broken up into 3 big projects, and that's, the first one is faster diagnosis and operational performance, the second one is early diagnosis, and the third one is treatment and care, and everything that we're asked to do falls into one of these 3 categories. So you probably know that one of the big objectives of NHS England in cancer is to diagnose more patients at an earlier stage. So there was an aim set out several years ago which said that they wanted to diagnose 75% of cancers at stage 1 and 2 by 2028. And at the moment, across the country, we're at about 50% of cancers getting diagnosed at stage 1 and 2. So we've got a bit to go on that. And so a lot of these programmes are based around that, and it's based around how we will get to that point by 2028. And the other thing that we also get some funding targets out. We know how much money we're getting for next year, and what the national team also do with this is they give us a kind of indicative spend, so they kind of advise us on how much they think we should be spending on each of these programs. And I don't know, in a way I guess it's like a little bit about how to prioritize it. In a way it's not, but you know, for example, they want us to spend about 50% of our allocation on faster diagnosis and operational performance. So that's, you know, that's the big target, you know, getting people in, get them diagnosed early, get them into treatment, you know, and then look at the operational performance going forwards. So it's quite interesting when you see how they think that we should be splitting up our money to deal with all these things. So I was just going to talk a little bit about how we get funded. I don't know if anybody wants to ask me any questions just now, or I'm happy to take questions as we go, or I can just keep going and then you can ask questions at the end.
Does anyone have any questions at the moment, or are you happy to go through to the end? Yeah, let's just go through to the end.
Yeah, great. So we basically get two pots of funding, and we get one pot is called SDF funding, or service development funding, and that's the pot that we get to manage these 3 big programs. And it's money that we're given. We're allowed to basically look across our system. We're allowed to decide where we think the money would be best spent. We do have these indicative percentages, but it's really up to us to look at the system and work with primary care and work with secondary care to figure out where in our system we need to put that money. And our pot for this year of SDF funding is about £8 million. Okay. And we also get targeted funding, and targeted funding is for specific NHS England projects that they want us to specifically concentrate on. So it's a lot of it is like innovative projects or specific things that they want us to look at. So this is the stuff that's on the list at the moment in terms of targeted funding. So this is kind of new projects that are coming along. Some of it is very well evidenced and it's just a new rollout. Some of it is at a less well evidenced stage, but there's enough evidence to support us using it, but we're still at a stage where we're trying to figure out, is it cost effective, is it a good use of time, you know, is it worth it? And there's a big list of things on here. We're involved in most of these projects, but not all of them. And some of them, when we get targeted funding sent us to us, some of it we're told we have to do the project, and sometimes we get the opportunity to bid for projects. So the likes of the community pharmacy project, that's a project where it's a pilot study looking at whether pharmacists could send patients into hospital with suspected cancer rather than patients having to go and present at their GP. So that's obviously, it's great given that we've got a shortage of GPs. It's also great for some groups that we know find it difficult to access or don't like to see their GP but may visit a pharmacist for advice. And so we bid for that project, and there was only 4 alliances, I think, around the country were successful in that, and we were one of the successful alliances. So we are just looking at that as a project at the moment. So it's basically, if you go to see the pharmacist and you have specific cancer symptoms, they will make a cancer referral into a trust for you, which is quite interesting. We're just looking at it. The kind of, I think the idea is that it will be for all cancer types in time, but we're starting on it in quite a small basis because it's a very new thing. And we're looking at it in terms of colorectal cancer and bowel cancer, and also lung cancer are the 2 tumour sites that we're looking at it in at the moment, which is quite interesting. The targeted lung health checks was another big success for us. So that's where patients who have smoked at any point in their lives get an invitation to attend for some screening for lung cancer. And it's a project that's been rolled out over the last couple of years across England. We were initially not successful in getting awarded that pilot, but last year we were offered the opportunity to take part in that, and we now have this we now have targeted lung health checks up and running in Swindon, and it is proving to be a very interesting and seems to be a very useful way of getting patients diagnosed with lung cancer a lot earlier, because we know that lung cancer is one of the cancers that that patients tend to be diagnosed quite late and have a poor outcome. And so we've already had a couple of patients go through the targeted lung health check in Swindon, be diagnosed with a lung cancer at an early stage, and be in a place where they can have surgery with curative intent, which is really great. So our plan this year is to roll out the targeted lung health checks across some further sites. It's not a project that we're able to roll out to everybody at once, but we're rolling it out over time, and it'll be getting rolled out to more sites across the Alliance geography this year, which is really exciting. The other one I'll just mention at the bottom is the GRAIL study, because that might be one that you've come across. It's been in the news quite a lot. And the GRAIL study is it's an American company that have invented a blood test which can pick up suspected cancer. And it's really, really exciting when it comes to early diagnosis. So it's even patients that have got no symptoms can have, you know, I mean, I'm saying patients, I'm even thinking as I say it, not even patients, people with no symptoms can have this test, and it can pick up certain cancers at a really early stage. Now, there's been a big study going on for the last 2 years across the NHS, where they've been rolling out the GRAIL test as part of a study. Again, that's not a study that we were accepted into at the time. We weren't successful in our bid for that, but there was a subsequent study that was run through the University of Oxford. And I guess because of our close links with the University of Oxford, we were offered to take part in that. So we've been taking part in that subsequent study for this blood test. It was called the Simplify study. And we've been taking part in that over the last year, which has been really exciting. But the reason it's on this slide is that if the study shows what we expect it to show by the end of this year, NHS England has committed to buying 1 million of these tests to roll out from 2024 onwards.
Right.
And we've been asked as a Cancer Alliance, because we weren't one of the ones picked initially, we've been asked to get ready to roll that test out from 2024. So it's really exciting. It seems to be really good at picking up some of the more difficult to diagnose cancers, things like pancreatic cancer, which is really exciting. So it's not absolutely clear what's happening yet, as I say, because the study has still to report, but the kind of preliminary results suggest that it's going to do what we expect it's going to do, and that we are going to roll this out from 2024. So that's really super exciting. So Lisa, I can't remember what I put. What I put in the next slide. What you put on the next slide for me to remind me to talk about. What else is on the next slide? Is it still me? Fine. So so the big things that we are trying to do this year, you know, the big concentration is on faster diagnosis. So getting patients, you know, getting patients into the system quicker, diagnosed quicker, and starting treatment quicker. Okay. Then there's operational performance, which is clearing the backlog. So there still are, you know, there still are quite a number of patients waiting for treatment, and it's coming down across the whole of our alliance, and it's coming down at quite a great rate at the moment. So we're very pleased with that. But a lot of the work we're doing is around improving that operational performance, not only to clear that backlog, but have it sustainably sorted so that going forwards that we are treating patients in a timely fashion. A lot of the early diagnosis work, as I say, is around trying to meet that 2028 target. And we're doing a lot of work across primary care, looking at pathways and looking at, you know, how to get patients into the system quicker. We're looking at messaging about how to get patients to present earlier so that the people know what the symptoms are, they know how to get in touch, these sorts of things. We've been doing a lot of work. I don't know if you were talking about it before I came, or it's planned to talk about in our Cancer Allies team, so that we're trying to make sure that we're working across that whole section of the community, and we're making sure that we're talking to everybody in our communities. And then the last bit is this treatment and care work stream, which is around making sure that patients are being treated in a way that is, you know, follows guidelines, it's up to date. If there's any new innovations or anything new coming along, that we're doing that we look at treatment variation, and we make sure, or we minimise as much as possible that kind of postcode lottery type of thing that you hear about so often in the news. And so I guess that's in a very short talk, mostly what we are working on over the next year. So I said I was going to try and keep it relatively short. I think I've gone on for quite a long time, but I mean, I'm happy to take any questions about it or go into any more detail about any of it if that's interesting to people.
Okay, thanks, Jen. Janet, you got your hand up first.
Yes, can I hear some amazing steps forward in terms of diagnosis, you know, coming from a patient. But can you tell me what is the national outlook? Because this is going to produce more higher figures, you know, people going into hospital or needing treatment or needing some sort of care. What's happening about that? Because, you know, it's all very well, but I've been on the other side where the hospitals are complaining we can't deal with this project that's been put on. You know, what is being done about that, please?
Okay, thanks, Janet.
I know, it's so interesting, isn't it? Because it's like we go out, for example, to look for prostate cancer, and then the urology departments are like, oh my goodness, we can't deal with all these patients.
Absolutely. Yes.
So we talk about this a lot, and part of the work that we're being asked to do this year is work with, for example, there's now regional diagnostics networks set up, who are being set up to manage diagnostic kind of demand and capacity, and there's also the community diagnostic hubs that have been set up, and we are being asked to work really closely with them to make sure that that we do have the diagnostic capacity to get patients through. And then I think the next bit of it is a lot of the kind of pathway development and a lot of the innovative stuff that goes along kind of changes the requirements. So I'm thinking, just off the top of my head, I'm thinking, for example, about personalised stratified follow-up. So if we put in place in personalised care, if we put in place a really good stratified follow-up pathway, patients don't necessarily need to do that 2-monthly checkup at the hospital. They have the ability to, you know, to monitor their symptoms, have that point of contact where they can talk to people, and potentially free up time for clinicians in the hospital to be doing different types of treatment. And then I guess the other bit of it is a lot of the work is going on around changing, that's not the right word, that using our workforce in a slightly different way to make different treatments available for different people and that kind of stuff, to try and give us that capacity to do more treatment. So that's kind of where that's going at the moment.
Okay, a couple of other people want to come in. Andrew.
Hi, I could see at least 3 of prostate cancer members on the call. So I was curious what your, you have prostate cancer as the second on that list. And I was wondering what you're doing in that area, because I'm actually also involved in that with another cancer alliance, East of England Cancer Alliance.
So interestingly, that went on the slide because it's one of the national offers, but we were unsuccessful in that bid. So there's a project going on nationally looking at prostate case finding. So actually going into GP practices and looking at patients who might, So we were unsuccessful in that. We were unsuccessful in that bid. So our primary care team are looking at the moment whether there is something that we could do locally, because it seems like such a great project, but we were unsuccessful in the bidding for the national project to get involved in that.
Okay.
Patrick?
Thank you. Thanks for that, Jen. That was sort of really interesting and informative. Couple of questions really, but they are related. Firstly, on a strategic level, I just wonder, how will patient voices be incorporated into the forthcoming service improvement plans? And sort of secondly, in relation to the targeted funding, I wondered, had there been any patient involvement in determining the Alliance's priorities in supporting the bids? And is there any subsequent patient involvement in the projects that are being run, such as the Grail, the community pharmacy and the lung health check?
Okay, thanks, Patrick. Jan?
Thanks for that, Patrick. So what I might actually do, I might actually look to Lisa and Lyndall to maybe come in and answer that. I mean, we've worked a lot and Lisa's done an amazing job at getting patients involved in a huge amount of the work that we're doing. And we're always looking to have more people involved in more stuff. But I don't know if one of you want to come in and answer Patrick's questions about that. You're probably better placed than I am.
Lisa,
Shall I start, Lisa? And you, by all means, then keep going, because I'm sure you've got more detail. But yes, you're absolutely right, Patrick. One of our things in the Alliance is that any project that's rolled out, that there should be a patient involved in that project to have that voice there, and that we're listening to what the priorities are of the patient and not what we think they are. So Lisa works very hard at trying to make sure our clinical advisory groups have patients involved. But as these other projects are going forward, that we do have someone on them. So things like the community pharmacy, we understand nationally there's a national sort of patient voice that's going into that, but we have had local conversations about who could potentially support that work. I think you'll find maybe later in the agenda we're going to ask for other people to potentially be involved in some of the project work. But you're right, we're with you with wanting to make sure that there is that voice in what we're doing. And things like targeted lung health check. I know in Swindon they've actually tried to work very closely with some of the health inequalities sort of groups to make sure that their voice is sort of feeding into some of how do we get these people to step forward and access the lung health checks. So yes, we're trying to make sure that we're looking at the diversity within the groups and who's getting involved, as well as trying to make sure that we do have that patient voice there. Lisa, is there anything else that we should add in?
I guess probably the other thing to mention is, as much as a patient group for the Thames Valley and for the Alliance, there are also other patient groups that support the trusts, support our national patient and partnership voices from the national team, as well as kind of area groups. So the Berkshire West Cancer Patient Partnership Group, and each of those who have attendance from a chair are invited to attend this meeting, so that we have that feed in, feed out mechanism. Does that cover everything, Patrick? What was your other question?
Patrick, anything you want to come back on?
Yeah, I just wonder, I mean, it's great to hear all that, but what I don't see in the Alliance is the principle of involving patients from the very beginning. So, for example, presumably at some point, the Alliance determined which of those targeted funds that they would determine to bid for. Now, was there any patient voice at that meeting? Was there any patient voice in the bids that were put together in order to try to gain that funding? Having got that funding, the first principle would be, presumably there is a group of people looking after each of those, whether it be the community pharmacy, the lung health checks, the Grail. I'm assuming somebody has responsibility for monitoring, helping to develop, organising that particular project.
Okay,
On
thanks,
that group, to me, first principle should be there should be a patient on that group.
Okay, thanks, Patrick. Jen, do you want to come back at that sort of, because what's Patrick asking is the kind of the front end decision. Is there patient involvement at that kind of making the decision about what to bid for and then following through?
Yeah, and I think, I mean, it's an interesting, you know, we have to, I guess, say that we haven't done that from that starting point. You know, the only time we've ever done that, Patrick, is when we worked with you, I guess, on the stuff when we did some of the faster diagnosis work. We're starting that off. But yeah, it's a great point. But as I say, you know, and I think Lisa said there, I think you're going to get asked later on in the meeting if anybody's interested in looking at some of that. So I take your point on that, absolutely. But thanks for raising that. Okay,
thanks. A couple of other people want to come in. Mark?
Yeah, I was going to come back on the question about if we spot a whole other cohort of patients with cancer, whether the system will be able to cope. In fact, there's a bit of a misunderstanding about that. What you're doing generally is moving the same patients forward in the pathway, particularly with like earlier diagnosis in lung cancer, for example. You don't radically change the amount of people with lung cancer. That goes in line with population growth and probably coming down because less people smoking. But what you're doing is those people who you spot would have developed lung cancer, and they would have developed lung cancer at a later stage and requiring perhaps different kinds of care. So what you've got to be aware of when you're doing these checks is that you're bringing cancer care forward. So you might have more patients having surgery, for example, and less patients needing palliative care. So there's a bit of a misunderstanding in the population generally that we're going to spot a whole other load more cancer. We're not really. We're going to spot the same cancers earlier.
Okay, thanks, Mark. Very helpful point. Jen, anything you want to add to that?
No, I think that's a really good point. Thanks, Mark.
Okay, Lauren, you want to come in?
Hi, yeah, I just wanted to bring it to the forum that we've got a patient group in Swindon that helped sort of give ideas about what we could do in terms of cancer support. One of the things that the patient group came up with was actually providing pastoral and emotion support from existing cancer patients to newly diagnosed cancer patients. We've just we've completed our pilot of the Cancer Buddy service and it's been really successful, and we're now going out to broaden the service. So we've got a Cancer Buddy hopefully got a Cancer Buddy coordinator and going up to about 30 Cancer Buddies to support approximately 60 patients which are newly diagnosed. So I think that's quite an exciting thing to share with people. There's something that's come out from a patient group support group that's then been rolled out as successful pilot and then gone to a wider initiative, and it's definitely something we'd be keen to share with other hospital trusts and things as the learning and how we've done it, and hopefully it will go on to carry on being very successful.
Okay, thanks, Lauren. I think that's a very important point. Anyone else want to?
I just want to add to that, William, if I may. In as much as that some of the patients on this group also belong to the Berkshire West Cancer Patient Partnership Group, and RBH is doing something very similar, or starting, to think about how they can do that kind of advocacy clinic companion role. And we've asked Michelle to come along to the meeting that Mark is hosting to actually share the intel and lessons learned and what's worked well. And see if we can all learn from the same kind of type of projects.
Yeah, I mean, I think it's really, really positive to hear kind of examples of kind of rollout when things have been successful. But I think one of my kind of frustrations in terms of experience is often there are pilots run and one never knows what then happens to those pilots. There's not necessarily information shared. Clearly all pilots have evaluation built in, but sometimes they just disappear into the ether. Obviously the ones that are successful do get rolled out, but again, there clearly has to be prioritization in terms of having the resources, and therefore, decision made about what you roll out and what you not. Any thoughts or comments on that, Jen?
I think, again, it's one of these, it's a really good point, and there's no there's no specific reason why things like that are not shared. It's probably just not, I mean, I'm not even going to dismiss it down as far as oversight. It's probably just people are really busy and I've moved on to the next thing rather than anything else. So it's a really good point, actually. Agreed.
Okay. I think it's probably important that we're more kind of structured in terms of feedback about what happens with pilots. Because often you get things at the front end. I'm never quite sure what's happening, you know, further down the road. Okay. Anyone else got any comments or questions for Jen? If not, thank you very much for that very interesting presentation, Jen. Thank you.
Thanks.
Okay, moving on then to item 6. Lisa, it's you on the engagement strategy.
Thanks ever so much, William. So in December's meeting, you may recall that Shelley and I shared a draft engagement strategy paper of all the information currently known between ourselves and Macmillan to actually use it as a base to sort of build upon and to create a strategy. Many thanks to those of you who have said that they'd like to get involved in a subgroup to take this forward. You may recall that William actually mentioned about a public consultation that was taking place at the beginning of the year regarding the generic engagement approach for the ICB. So Shelley and I have had a follow-up conversation with Vicky from the ICB, Vicky, who presented earlier on, to try to determine sort of what the ICB and ICP have been working on and to make sure that we don't sort of duplicate effort. So their report from that public engagement sort of questioning, face-to-face seminars, webinars, etc., went live in March. Well, also to say was published rather than went live at the beginning of March. I've put a link in these slides, which obviously I'll share. So we still want to develop this work specifically for Thames Valley and Macmillan, but we're going to temporarily pause it at the moment, just until we know what sort of the next steps are for the ICP, because there doesn't seem in the report at the moment to be a dedicated element around cancer. But of course, I think there's more of a sort of generic approach about what are the steps that we take forward about our engagement strategy. Like Patrick was mentioning, how and when do we get patients involved? So it is something that we want to build upon, and I'll be in touch with those subgroup members who have showed an interest to make sure that we co-produce this piece of work. So that was all I wanted to share, William, on that.
Okay, thank you. If I could just add something, I mean, I think it's very easy to get caught up and get confused with all these kind of letters, you know, ICS, ICP, ICP, you know, they're all different parts of the system, you know, the integrated care system, you know, the ICB is the bit of the health service that's monitoring it and responsible for it. And the ICP is that joint body with local authorities and voluntary organisations and health who have a responsibility to develop the plan. So I think it'd be, you know, if people are interested, do take the opportunity to have a look at the plan. It's quite detailed, and as Lisa said, there was an awful lot of work going into the consultation about it. It is a bit unfortunate that perhaps a number of people have said this, that there isn't enough detail in the plan about what that means about particular conditions, cancer being one of them. The response certainly I've had from NHS staff, from the ICB staff, is that that kind of detail is going to be coming out in the operational plans, which each place in the ICS will come up with. So the ICP's strategic plan is really the starting point, and you know the ICB is very clear that we're in very early days, and therefore we would need to look at coming back and reviewing it in a year's time. So I think we'll need to look at what actually happens with operational delivery. And again, we would want to make sure that at each place level that we understand what the priorities are in cancer that are being focused on. Okay, thank you, Lisa. Move on then to item 7 then, Abby, and about the health inequalities. Thank you.
Thank you. I'll share my screen now. I know, Lisa, apologies, I wasn't able to send it. I wasn't able to. That's so,
great. Okay.
So I will just see if I can do a slideshow.
So Abby, just so you're aware, you're very faint with regards to your audio. So just in case people mention,
Yeah, I am
I know
so
you've been
sorry.
having troubles.
Yeah, can you hear me? I've joined on my phone. Is it better at all or not?
Yeah.
Yeah.
Yeah, I think so.
Okay.
Yeah, let's carry on.
Yeah. Okay. So Lisa has asked me to come and talk a bit about the Cancer Allies program. I think she's asked me to talk about just present a bit of data around. So I'm going to be showing data around deprivation and staging. She wants me to talk about the Core 20+5, which is the NHS England's strategy for, obviously addressing health inequalities. And she also wants me to talk about what the Cancer Allies program, what we're doing in response to, the data and the strategy. So I think I have been on this in this meeting. I think I was the very first one to talk about the Cancer Allies program. So just a bit of a background about the Cancer Allies. So obviously, addressing health inequalities is a key part of what we do within the cancer services. So the Thames Valley Cancer Alliance has developed this program, and we call it the Cancer Allies. And it's basically about bringing together all of the people likely to be affected by health inequalities and just deliberating together. And it's about co-producing. So it's about understanding from the perspective of the patients or from the groups, the barriers, to accessing healthcare, understanding that as an alliance, we don't have the answers, but that we look to the people who are really affected, by the issues to understand the barriers and then to co-produce the interventions. And the main aim is really the Cancer Allies program at the moment is really focused on the front end of the pathway, which is about that timely presentation, getting people onto this, to be diagnosed early, working with communities to increase the awareness of signs and symptoms of cancer. And we really work with community groups. We understand that, the message is as important as the messenger is as important as the message. So it's not just about our message, but it's about the platform for the messaging, the people who are delivering the messaging. There's that thing about people like me talking to me. People tend to listen to people like them talking to them and understanding that there are religious nuances, cultural nuances, affecting how people perceive communications, and just making sure that messaging is tailored to specific communities and groups. So that's kind of like a brief overview of the Cancer Allies program. We do have a Cancer Allies kind of like introductory pack, which I can actually share with Lisa to share with the notes. So that gives more information about the Cancer Allies. And then I'll just touch briefly on the Core 20+5. So the Core 20+5 initiative is the NHS England's strategy for addressing health inequalities. And it is based on, so the Core 20 is actually, it is based on the premise that to identify the 20% most deprived population. So obviously for NHSE, that's the whole country, identify the 20%, and that's the Core 20, that's the 20% most deprived population group. And then the plus is also, in addition to that 20%, they are also at the high CS level, or when you think about Oxfordshire, Buckinghamshire, Swindon, at that level, there are some other population groups that actually experiencing poorer than average outcomes, and to identify those ones, and those ones may not be captured within the 20%, but at that granular level, CCGs, ICSs are able to identify those populations, and so that plus captures this group as well. And then the 5 is 5 clinical areas. So as an organization, NHSE has identified 5 clinical areas to focus this work on, and that's maternity, mental health, CVD. Obviously, cancer is one of those, and that's where that's where we are involved. There's also hypertension case finding, but early diagnosis of cancer is one of the 5 clinical areas. So that's an overview of the Core 20+5 at an organization level and NHSE level. For the Alliance, we have also identified our own Core 20+5, which is more, obviously tailored to Thames Valley patch. And Thames Valley patch, I'm talking about Buckinghamshire, Oxfordshire, Berkshire West, and of course, Swindon. I've just put a little key info here. Obviously, when we talk about 20% most deprived, you might be wondering that how do you identify that most deprived population? So there's kind of like some key index to identify deprivation, and it consists of 7 domains of deprivation. So they look at deprivation from the factors are income, employment, health and disability, education, skills and training, crime. So all of this is what makes up the deprivation factors. So when you're talking about 20%, you're looking at the 20% within these factors in any population. So for the Alliance, obviously to just bring it down, like I said, even though cancer is one of the 5, but within the Alliance, what we've done is to determine our own 20% most deprived population just across those 4 areas I've mentioned, to look at our 20% most deprived. And our 5, obviously, whereas the 5 for the NHSE is 5 clinical areas, for the Alliance, we're looking at the 5 tumors groups with the highest number of shortfalls post-COVID. And that really talks about, so obviously we know that referral rates dropped after, during COVID, and that we've seen a significant drop in referral rates. But there are specific tumor sites that have experienced more drops than others. So we've looked at those. So we've used data from 2019 as a baseline, comparing the referral rates, the drop in referral rates between from before COVID up until now. I've identified these 5 tumor groups. So obviously you understand that health inequalities is vast. There's lots of work. But obviously, in order to be able to make reasonable progress, it's good to be able to distill down and focus, on a small area at any one time. So we've identified our 5 tumor sites with that drop in referral rates, and that's the 5 on here: urology, upper GI, lower GI, head and neck, and gynae. So that's just a bit about core 20 plus 5, obviously from an NHSC angle and from an Alliance perspective, what we're doing around core 20 plus 5. I'm going to be showing some data. If you do have any question, because I'm sharing my screen, I can only see William now. So hopefully you let me know if anyone raises up their hand, but I'll just carry on. So looking at deprivation, and I have quite a few slides. So the first one is really about, in terms of cancers diagnosed in 2019, we had 15,267 cases of cancer diagnosis. However, you see that what's interesting is that if you look at this chart, you see that the more deprived groups have the fewer number of diagnoses. So in our most deprived groups, and I know Nathan is on the call, he's our data analyst, and he's been really helping me to get this data. So what I wanted to see the deprivation broken down. This slide I showed earlier showed different factors of deprivation, and I would have loved to see broken down into those various factors. But unfortunately, that data is not available. It's just available as the deprived group, rather than it doesn't break it down into income, ethnicity, and all of that. So it doesn't do that. But we're still working on, how much granular level of data we can get. But in terms of what's available now, we know that in terms of the 15,267 cancers diagnosed in 2019, only 480 diagnoses came from our most deprived. And you can see that the least deprived group has the most diagnoses. Obviously, this is not because people in the most deprived areas don't catch cancer. It just points to the fact that they are not presenting early. And so the next slide, again, this is just a deprivation time series again. It just shows that. So if you look at from 2018 to 2021, and I'm just going to focus on the green being the most deprived quintile of our population. If you look at 2018, you can see that, consistently, referrals have always been lower in the most deprived group. Obviously, with every group, you see a drop in April 2020, COVID, peak of COVID, there was a drop. But post-COVID, if you just look at the blue, which is the least deprived, you can see that significant spike. So referral numbers have really gone up there. But if you look at the green, even though it's picked up a bit, you can see that there's still a lot of work to be done. It's quite low. So the most deprived group have the lowest number of referrals. And again, this is another graph on deprivation. And this again just shows you proportion of referrals by different groups per month. It just compares, when you look at the comparison. So take March for example, March 2019, March 2020, and March 2021, you see that the green, which is our most deprived group again, has the lowest number of referrals in comparison to the other areas. So in March 2019, it was 3.2% of all the cancers, 3.2 from the most deprived areas. But if you come to now, we have some data showing 2020, 2021 February, it's 2.6%. So it's actually, the number is quite low. So we know definitely that there's some significant work that we need to do with our most deprived groups, in terms of how, addressing that health inequalities. Again, this is obviously deprivation across the Thames Valley by tumor sites. And again, you see that the least deprived, when you look at any of the types of tumor, the least deprived tend to have the significant number of referrals, and the most deprived tend to have the lowest number of referrals, even across different, so whichever way you look at it, if you look at it by tumor site groups, you still see that significant variation. By trust, this is also by trust. So we just cut the data in different areas, just to give you a clear picture of, of Thames Valley. So by trust again, and obviously there are more, the trust we have here, my focus is really on the TVCA patch. And this is also by trust, but also by patient postcode. So like I said to you, because we couldn't really break down the deprivation by those separate factors, I've asked for it to be shown to me by postcode, because that enables us to focus on particular areas and you can see again that across all of our trusts, you can see that across most of our trust again, you see in terms of referrals, from whole UH, we have a significant number of referrals, in the list, number one was deprived and the second was deprived groups. We have 153 and 302. So obviously we know that quite a number of our deprived population is based in that Oxfordshire patch. So looking at it by postcode. Also, HBH is another significant one in terms of that significant number of where our deprived population seems to be based. Again, Buckinghamshire is another example. You can see there that we have 151, cancer diagnoses in the second most deprived groups. I think basically what this picture shows is that across all of the Thames Valley areas, whether it's Buckinghamshire, Oxfordshire, we have pockets of deprivation. So in terms of our health inequalities work, we need to be looking at all of those areas. We have pockets of deprivation in every area, whether it's Swindon, whether it's Buckinghamshire, it's all spread across. I think this is the last slide about data, and this just shows a snapshot. So I've showed you the data by deprivation, just to give you an idea of in deprivation and where those are kind of like localized. But this is the staging data, and staging is about the stage of the diagnosis. Obviously, we have stage 1, stage 2, and stage 3, and stage 4. So we have 4 stages. But the NHS long-term plan, the ambition is that 75% of cancers are diagnosed at stages 1 and 2 by 2028. Obviously, there are key benefits to diagnosing cancers early. If picked early, the likelihood of survival is higher. So that's the grand ambition, that we diagnose cancers earlier. Now, the two graphs here, so you see the total number of cancers diagnosed, that's between 2013 and 2019. And this is broken down by the stages of diagnosis. So as an example, if I look at 2019, which is the more recent one, we had more cancers diagnosed at stage 1 than stage 4, which is good news. That's good news that we are picking more. I'm not sure we're seeing the graph that you're talking about. This time I'm still looking at an old graph.
Yes, we're still looking at the
We've still got deprivation.
That's interesting. I've moved to the staging one, but you can't see it.
No, I know.
You froze on us for a little while, Abby.
So when was the last? What was the last thing you heard me say?
We're,
can go back.
you're showing the deprivation slide.
We've been able to hear you. It just hasn't changed the view.
Yeah.
Okay. So I'll stop sharing and then I'll share again. Okay.
Okay.
I'll just stop sharing for a minute and then I'll share again. Let me just come here. And you can still hear me. All right.
Yes, I still hear you.
Yeah. Okay. I guess because I'm on my phone, I'm using phone audio, so it's not. So I'll try again. Let me know if I'm sharing my screen now. Anything yet?
Not yet, no.
Nothing yet,
Okay.
Abby.
No.
Okay.
Okay. Abby, the last thing you were talking about was about the 75% target.
Yeah.
So
can you see me now? Can you see the screen now?
No.
No. Oh, that's not good, is it? Okay, Lisa, let me send this to you. It's hard to talk through this if you're not seeing it. So Lisa, I'm going to just send it to you right away.
Okay, tell you what.
And then,
okay.
And then
we can include it in the pack that we send out as well.
Yes.
Anyway. So.
Yes, include it in the pack. Abby, in the absence of being able to see it, is there any kind of final points you want to make?
Yeah. So the point. So I was talking about the staging data, and the basically is that there's an ambition that all cancers are stages 1 and 2 are diagnosed at 75%. But at the moment, at an alliance level, in terms of where we are at an alliance level, we have 57.75% of cancers diagnosed at stages 1 and 2. So that's where we are as an alliance. But that 57.75 doesn't actually take account of some cancers that are not staged or missing data, But this is just taking a snapshot of staged cancers, stages 1 to 4. The alliance is at 57.75% of stages 1 and 2. So obviously that presents kind of like a good picture in terms of where we are. But like I said, that doesn't take account of cancers that are not staged at all. So there's obviously more work for us to do. So in terms of the cancer allies, our approach remains the same. It's really around collaboration, working with community groups, working with obviously the groups we have identified in terms of that we work closely with are BAMEs. We work with the BAME communities. We work with people with learning disabilities, and obviously the health inclusion groups as well. In terms of just working together to identify the barriers, to develop targeted campaigns, focused campaigns. So we have been doing this for the past 2 years now. So we do have quite a good number of allies that we are working with across different communities, faith leaders. We've done some work with learning disability teams as well. But there's obviously lots to do. So we've got our comms leads on the call. So we have the Help You campaign that the NHS England runs across the year. So obviously we do some focused work, and the focus will be on those 5 tumor sites that we've identified. So there'll be focused work on creating assets, resources that really resonate with the groups that we're trying to get across to, ensuring that we share information on the right platform. We're working with our screening team just to develop screening campaigns, all with the aim of, obviously letting people recognize the signs and symptoms of cancer, obviously encouraging people to present early, recognizing that early presentation can save life. And in terms of some of the other projects that we're running across the Alliance, as an example, the targeted lung health check, which we're about to roll out across the patch. We're making sure that we are looking at areas of high deprivation, areas of known health inequalities, and focusing those projects in those areas as well. Like I said, I think at the heart of this is co-production. The Alliance is not leading the production of those resources, but we are working with those groups to develop the resources. Thank you.
Okay, thank you very much, Abby. Any quick points for Abby, questions or comments? Okay, Abby, thanks for that. It's a lot of data. There's a lot to absorb, but clearly there's also a significant amount going on. And I think one of the things that people I think we need to acknowledge about Bob is that their perception clearly of our area is that we're kind of very well off, and therefore those kind of hidden pockets of deprivation often remain hidden. So I think it's very helpful, the data you shared, to try and help us kind of deal with that perception. Thank you very much.
Thank
Lisa, can we move on to your bit about engagement? Thank you.
Just check that I'm off mute. Okay, so my update is to try and kind of link the presentation that Abby's done with how we take some steps forward within the Alliance, and also referencing back to the sort of planning guidance that has come out and how patient involvement, patient engagement is incorporated into that. And I think that touches upon some of the comments as well that sort of Patrick's made, and I'd really like for others to comment going forward at the end of this slot. So within the planning pack, there was a national sort of delivery ask from the Alliance to establish and maintain people and community engagement structure to enable co-production throughout our work programme. So we've spoken about this before, this feed-in, feed-out mechanism and all the various different groups that we have incorporated within the Alliance, and obviously our outreach outside as well. As mentioned sort of in previous meetings, the evidence of effective involvement of people and communities is actually a statutory duty. And this must go further than just consultation styles of engagement, just asking patients to sort of sense check documents that we've created. We really need to involve patients right from the very beginning, and carers as well, those with basically lived experience of cancer. So I have in the slide put the two links with regards to the statutory duty, just for people's reference if they would like to obviously refer to it at another date. But we basically need to ensure that the peoples and community within Thames Valley have an equal opportunity to influence and to sort of make the decisions as partners regarding the work that we're taking forward. So let me go on to here. So there was an ask on the Alliance in respect of working with the systems and trusts to ensure that they've got insight and feedback, and to obviously develop the quality improvement action plans to improve experience of care. Some will lead on this independently, but alliances will work with our ICSs, our ICBs and our regional teams. So to give you some examples, working with providers and the systems to act on the results of perhaps the qualitative, quantitative and narrative feedback from various different surveys, whether or not that's the cancer patient experience surveys that we've spoken about before, and obviously when they were published we shared those details with the group, friends and family tests that the trusts carry out, patient reported outcome measures, complaints and digital storytelling as well. So this could be work across sort of the whole cancer patient pathway, including primary care, secondary care and obviously tertiary care. So other activities could include promoting and supporting the completion of the CPES report that comes out. We obviously work alongside trusts, but they're the main ones that kind of instigate the comms on that initially. But we've got our comms lead on the call today that we may be able to kind of support that going forward as well. And encouraging and supporting trusts to participate in the Cancer Care Improvement Collaborative. So spreading the learning from best practice across the Alliance footprints. And I know of various different activities within Great Western and RBH that both have participated within that particular improvement collaboration, sorry. So I just wanted to kind of stock take on where we are as an Alliance and what we would like to do. So, we currently already have a patient partnership group, but we really need to build upon its membership, reflecting the local population we support. Just like what Abby was saying, we need to widen our community outreach through the Cancer Allies programme and to help focus the health inequalities that we have across the whole of that Thames Valley, whether or not it's Buckinghamshire, Oxfordshire or Bucks. I mentioned earlier on about linking in with other PPG groups to make sure that we have that representation, and I guess all of us are informed of the work that we're doing, and that's spread within the patient voice within those particular groups. And that also includes leading on recruitment to support any vacancies that our national colleagues state that they have within the Patient Public Voice Forum. I think with regards to, you know, improving on the diversity of our forum, we have to be mindful of sort of all 9 characteristics, protected characteristics. And this is something that I really would like to, while working hand in hand with our Cancer Allies programme, see our PPG evolve. And I think, you know, by having existing and ongoing patient engagement events, we have the capacity to build upon that and to make sure that we also have further public engagement events to promote the work that we're doing, and obviously to meet some of those national priorities around early diagnosis. So from our last meeting, we said about hosting our next summer meeting face-to-face. So what I wanted to kind of share with the group today, and I guess in relation to support the conversations and next steps around the engagement work we want to take forward. Abby's obviously mentioned about our local communities, the health inequalities that we are aware that data presents in them, and, you know, looking at how we can, as a group, have various conversations within maybe our own patient networks, our community outreach, and sort of make sure that coming into the Alliance we have some sort of some structure, some ideas, some sort of priorities that we kind of want to address. I mean, I think ultimately us meeting in June will give us an opportunity to meet in person, because we haven't done that since the group was set up. But I'd really like for it to be more than just a meeting. I think we have an opportunity to actually develop it as an event, and to maybe look at some of the topics that we've covered off today. So these are really sort of just prompts for me, practicalities, logistics of the event. Obviously we cover such a wide patch within the Alliance, so where we host an event has to be important for people to be able to access it. So, you know, whether or not it's in Buckinghamshire, Oxfordshire, Berkshire, we need to be sort of aware that people can get to it. If we want to extend our meeting, so rather than the 2 hours that we have an afternoon with lunch, and then we make it more of a sort of a network event as well. And I just wanted to touch upon sort of travel expenses, appreciating that all of our patient reps are voluntary. But if we're wanting to come together face to face, then the Alliance, as part of the NHS policy, will pay for travel expenses to get to various different events. So looking at our June meeting, and as I say, I want to make it more than just going through the minutes, going through the actions. Can we sort of have a workshop discussion? Can we sort of have maybe stakeholder stands? Really, I'm putting it out to you how we want to maybe structure the event, who we want to invite. We've got our comms lead on the call as well, that will obviously be able to have maybe a mini subgroup that we work alongside all of the details. So William, I know that you wanted to kind of lead on this a little bit, so I don't want to take your thunder as such, but have I covered everything that I needed to just there?
Yes, I mean, let's just pause and sort of, you know, take these bit by bit. I think the important thing is to kind of link this back to the previous slide, but because it's about how do we focus on supporting and developing engagement. It's very easy for us to talk about it, and it's great that we all sort of come on this call. But I think we all recognise that there's need to do more. But at the end of the day, we're all still volunteers. So how do we put all those things together? And certainly, I would support you know, the idea completely of us having a face-to-face meeting. So let's just check out just that principle. Are people happy and keen for us to have a face-to-face meeting in June?
Yeah, just say I represent Buckinghamshire Disability Service, and I know from our point of view, we would be concerned if we had a face-to-face meeting if adequate COVID precautions were not taken, for example, well-ventilated rooms, etc., for the safety of people generally.
Yeah, I think we need to take all those things on board. You know, even though, you know, clearly we're kind of moving along quite a lot, but clearly we need to have the appropriate things in place. Jill,
you.
you mentioned dispatches there. Do you want to come in?
Hi. We can use all what we learned from putting the showcase event together last December. I'll certainly work with Lisa to make sure that the comms are all in order. But I think she's right in that choosing a key reason that's different to your normal meetings is going to be really important, and whether recruitment is part of that, and opening it up to for a time to people from the communities who maybe want to come and meet you all before deciding whether or not they'd like to be a part of the PPG. Don't know if that's enough of a hook to get people in, but certainly it's something that we can promote on our social media platforms and also through local and regional media.
Okay, thanks, Jill. I mean, there are lots of kind of practicalities for us to look at. We'll come on to the issue about planning and involvement with that in a moment. But in terms of practicalities and logistics, are people happy with having something which is half a day, say in the afternoon, starting with lunch?
Mm-hmm.
Yes. Okay. We've covered the point about travel expenses. Patrick, do you want to come in?
Yeah, thanks, William. I think that the point I'd like to make is I think it depends very much on the purpose of the meeting. I think post-COVID, most organisations, certainly that I've been volunteering with, have moved into some face-to-face meetings, some continued online.
Yeah.
But I think it's very much to do with why do we need to meet face-to-face? And I think that's the crucial thing. It's knowing what the agenda is and what the purpose is. And I think even if we do meet face-to-face, I think it's also important to allow some sort of hybrid meeting so that some people who have vulnerabilities for all sorts of reasons may want to attend but aren't able to, should have access to such a meeting remotely. And I think increasingly I've seen organisations running those hybrid meetings where individuals can engage, but in a way that meets their own particular needs.
Okay, I think that's a very important point. Lisa, do you want to come back on that?
Yeah, I'm just conscious that I don't want to morph too much into this event initially. I mean, I think because we haven't met as a group face to face since we first became a PPG, I think that's kind of a priority. But then looking at the structure and maybe trying not to put too much in, but making sure that we make it more than just a meeting. So I mentioned maybe about hosting other public engagement events going forward, but it would be good to maybe ask the group today if they have any ideas about what we might like to discuss.
Yes, okay, let's just move on to that in a moment. But just before we do that, I think that the other thing, and just practicality I want to touch on is location. I'm not talking about a particular venue, but I think we need to have some kind of idea about where in the Thames Valley is going to be most convenient for as many people as possible to get to. I mean, I must admit my immediate thought is probably Oxford.
Yeah.
Around Oxford, just because of the centrality of where we are, but I'm open to any other thoughts and proposals. Patrick, is that a Lexi hand, or do you want to come back?
Apologies, no, it's an old hand. Thank you.
Okay. Oh, you're not an old hand, Patrick.
I think Oxford's a good idea.
Sorry, could you just repeat that?
Yeah.
I think Oxford's a good location. It's quite central for everyone. I think in the Alliance sounds sensible.
Yeah, are people happy with that, Asa?
Yeah.
Okay.
Yeah.
Well, let's move on then to some ideas about structure. I think what would be really helpful is, as Lisa's highlighted that in the last bullet point, if we had a few people involved in a group to help plan. Because I mean, Patrick's absolutely right. It has to be something that you want to come to. It's not sufficient just to be able to join, to see people, although I think that kind of social thing and that kind of actually being able to see each other face to face is quite an important element. But I think in order to make it interesting and attractive, what I certainly don't want to do is sort of say, well, okay, Lisa and I'll go off and plan it, because I don't think that is actually sufficient. We actually need to have involvement and engagement from people to actually come up with something that's going to, meet people's expectations. So I think the approach of having a subgroup, I think, is something which I think is helpful. I'm always reluctant to do this, but I think I don't have any other option. Have we any volunteers? Is anyone who would like to join Lisa and I in a working group in order to plan? And obviously we'd probably be doing the planning virtually, I would expect. Any immediate people who want to? Whose hand do I? Yeah, Vicky, do you want to come in and comment on that, or?
I was just going to say I'm happy to help.
Okay. Anyone else?
And just to comment with regards to kind of the logistics of it, we actually have a central sort of event team that would help coordinate and look at, the funding of where this would need to be. So we wouldn't necessarily have to source the venue without that kind of support. It's more looking at the content of what it is we want to talk about.
Okay. Well, let me not carry on putting people on the spot. If you want to reflect on it and think it's something you'd like to participate in, can you drop Lisa an email, say by the end of tomorrow, so that we have some, and then we'll look at getting the group of us together. People happy with that? So if you're interested, just drop Lisa a quick email saying, yes, I'm interested. And we'll then sort out the practicalities from there on. Okay. And I think in terms of the makeup, again, this is, obviously up to the group to discuss, but certainly I think it's important that we have a combination of kind of probably a presentation or two, but workshops as well, because I think we actually need as much opportunity as possible to talk to each other, to be doing that, and that's going to be most productive probably in smaller groups. Peter, you got your hand up because you want to speak?
Yes, I would support that, William.
Okay, thank you. Okay. Anything else anyone wants to say on the idea of a June get-together meeting? So we're happy with that in principle, and anyone who's interested, Lisa has already made some a note of the existing volunteers, but I'd like one or two more. So by the end of tomorrow, perhaps, if you could let Lisa know that. Okay, thank you very much. That takes us to the end of the agenda. Any other business? Does anyone have anything else that they'd like to raise before we wrap up? Christine?
Yes, hi. My name's Chris. I'm a Macmillan engagement lead, covering Berkshire, Buckinghamshire and Milton Keynes. It was just really, excuse me, to give you an update on a recent event that we held around patient voice in Bucks. Lisa was there helping out with facilitation. Basically, this was in conjunction with many partners, mainly Bucks Healthcare Trust, as they were working through their new cancer strategy at the time, just bringing a lot of people with lived experience together to see where they were. What we were focusing on, 3 elements of the cancer journey, which was sorry, lost my thread. 3 elements of cancer journey, which was diagnosis, treatment, and living with and beyond cancer. What we did, it was a big face-to-face event. We had over 50 people there, mainly people with lived experience. And we just had workshop table discussions like you're focusing on for the PPG event in June, just asking people what was made the experience poor, what you want health professionals to know about and to be told, and what would make a difference to patients and families that would improve patient experience. We had lots of feedback on these sessions, and it was very successful. People gave us their views, gave us their ideas and suggestions. So at the end, what we did with the next steps, we were going to put all that feedback together, do a report and see where we go from there. We had 21 people who signed up to help us to move forward with this. So the latest is we've coordinated all the feedback together under different subjects. And what we're doing is holding a first Teams meeting just with those 21 people with lived experience who have offered to help, just to go through that feedback and see what they want to concentrate on. Because the idea of this all the way along is to try and create a new patient partnership in Bucks. There was one years ago, but it folded, and it's such an important mechanism, I think that has been proved through Berkshire West, and also there's another good one in Milton Keynes over the border. So that is the idea, to try and to get people to look at the feedback. How would a cancer patient partnership look like? And as I said, how we move forward with this. But it's a good and timely piece of work, which again, if we manage to create the partnership, it would feed into the PPG, so to create a lot more representation. So happy to feedback on that as it happens and the results of the first meeting, because we want to have wider input, obviously, from other partners from when we move forward with this. So as I said, just a quick update that something was happening in Bucks that we're hoping to develop.
Okay, thanks, Chris. We've got a few more hands up, so let's be focused and brief if we can, please. Alex.
Hi, good afternoon. Those of you who don't know me, I'm Alex Miles. I'm the patient rep for the 7 prostate cancer groups in our patch. The Chilterns PCSG have asked me just to make you aware of some stuff that they're doing. Firstly, they're running some free PSA testing sessions on July the 15th and October the 28th. They're looking for 350 victims to come along and have blood drawn. And they're quite eager for us to let anyone who might be interested know about those things. Okay. They've also got an awareness event taking place at the Jordans Village Hall on March the 24th. That's obviously prostate cancer awareness. If you're interested in any of that, I'll put my email address in the chat, and also the website address for Chiltern's Prostate Cancer Support Group. Thank you, William.
Okay, thanks. Andrew?
Oh, hi. Yeah, a couple of things. A couple of things I want to mention. One, we've got a relatively new consultant in Reading in urology doing. Sorry, can anyone mute who's not talking? No, it's very difficult to talk. That's better, thanks. A consultant who has approached the Reading Prostate Cancer Support Group, specifically with help for getting what are called vacuum erection devices or pumps, which are really key to a number of procedures, particularly around prostate cancer and some other treatments. And for reasons that we're not quite clear, Reading has decided that these are not to be provided to patients. And there are like 2 or 3 bits of the country where this happened, either White's another area. But in most of the country it is available, and he's come obviously from London where they're routinely supplied to patients. And I'm wondering who we need to contact to find out why this was done and to get it reversed. It may not be this group, but I'm guessing that somebody on this group might know who we would need to contact.
Okay, thank you.
William, Mark's put up his hand. I don't know if that's in connection with answering Andrew's question.
It is. That's certainly news to me, Andrew. So I'd be happy to take it forward. Just drop me a line, and I'll see. I'll put you in touch with some people who might be able to help you.
Oh, okay. So I'm guessing this might be an ICB issue or something like that.
It sounds like commissioning problem, doesn't it? But let me know.
I think it was the same with the CCG before. But yes, we need to get this kind of looked at because it's quite an important issue.
Yeah, sure. Happy to take it forward.
Well, thanks, Mark. I'll get in touch with you. The other thing I was going to say is I obviously follow the TVCA on Twitter and I retweet some of your tweets and things. One thing I would say, though, this is becoming sort of quite important because there's now research that shows it, and that is please stop talking about symptoms of prostate cancer. We now know that prostate cancer does not have any symptoms until it's incurable. So you need to catch people who are symptomless. But talking about symptoms of prostate cancer is actually dissuading people who have it but don't have any symptoms, which is pretty much everyone who's curable, from coming forward. So there's some, I can point to some research about this if necessary, but that's quite important messaging change, I think.
It is a very important message.
Can I come in on that, please, William?
Yes, please do.
Thanks, Andrew. I saw your comment on Twitter. Just to let you know that anything that is published is approved by somebody with clinical excellence, and also that was also approved by Prostate Cancer UK. So it does go through a process to check the clinical integrity and accuracy of everything that's in there. But I am speaking to the urologist Tom Leslie, who's the CAG lead, who I'm working with on the prostate campaign, because we're doing some media interviews. So I was going to raise it with him to follow it up.
Yes.
But it does go through a protocol to ensure that it has integrity before anything's published.
Okay, this is an area where GPs are hopelessly out of date. So this is an area which PC UK is trying to update GPs on. The support groups have known this for years, because if you go through our support groups, almost nobody was diagnosed, ever had any symptoms. But GPs look for people with symptoms, so of course they miss the prostate cancer patients. But a paper was published last year saying we've got to stop talking about symptoms of prostate cancer because it doesn't have any.
Yeah, we talk about age and other risks as well in there. So we cover. So it has been approved. I just wanted to reassure you on that.
Okay, sounds like the people approving it need a bit of need bringing up to date.
Okay, I'll put you in touch with the consultant urologist who approved it.
Yeah, that's fine.
Okay, thanks, Andrew. Very helpful. And Vicky, want to come in? Are you still there, Vicky?
Yeah, so yeah, I'm here. I just wanted to update on 2 requests that we'd had as well recently. One from the Buckingham Psychology Steering Group that are rolling out psychology support for GPs to refer patients straight into, and they would like patient participation on their group. And also in Oxford, the late effects service, which is just in its very early stages. So that's looking at late effects from radiotherapy treatment, and that's a 3-year commissioned project that's just about to start. So they would like some patient input on that project as well. Both of them will be online meetings. So if anyone was interested, then let me know.
Okay, thanks, Vicky.
Thank you.
Okay, I don't think there are any other hands up that I haven't called. Anyone I've missed? No? Okay, I think that takes us to the end of any other business. We don't have any other parish notices? No, nothing else anyone wants to advertise? Okay, great. Well, thank you very much to everyone for joining today. Thanks particularly to the presenters, and thanks everyone for engaging. And the next big thing is obviously our face-to-face. So let's sort of focus on working up a program which is going to be interesting, and I look forward to seeing as many of you as possible. Take care. Thanks very much.
Thank you.
Bye. Thank you.
Thank you. Goodbye.
Thank you.